Okay, good afternoon, everyone. Happy St. Patrick's Day. Okay, so to get us started, do I have any volunteers to read the HPI?
I'll
Yes,
read it.
yes, and oh, sorry, go ahead,
No,
Max.
go ahead, Aria.
No, Sananda was very excited about this. Clearly, earlier. I saw her reading about galactorrhea, but 28-year-old woman with past medical history of galactorrhea presented with 2 days of fatigue, lightheadedness, and feeling, quote, like I am dying, and with dark spots in her vision, headache, and decreased appetite. She reports never having had similar symptoms before, but has been having ongoing issues with galactorrhea on and off for 2 years.
Excellent, Ariella.
So the reason you saw me this excited is I was just super confused as to why galactorrhea would happen in someone with those symptoms. So that I was looking that up to see if I could share anything with you guys. But basically, I don't know if this works. This will be my first time trying this. But what I discovered, sorry to interrupt so early, is that we can definitely separate this in hypothalamic and non-hypothalamic causes. And if you're thinking of, and I'm sorry, Sarah, I hope I'm not giving anything away. But the two hypothalamic causes could be either like, obviously you guys know like prolactinomas, but prolactinomas, they are the commonest like hormone secreting tumors in the brain, but they will only secrete, like significant prolactin levels when they're macroprolactinomas, which means they're greater than 1 centimeter in size. And that is not that common. And then if you have any other like tumors that are compressing the pituitary stalk, then definitely they could decrease like the inhibition of prolactin because they're kind of interrupting that flow of hormones, and that could cause this kind of hyperprolactinemia, perhaps if this is even the case, to cause like milk production. And then the other thing, and I was wondering, like, could there be anything else? And I remembered from medical school that if you have hypothyroidism and you have a low TSH or a low T4, T3, you may also have like an increase in TRH. And TRH does like result in hyperprolactinemia because it's directly stimulating the hypothalamus that way. And obviously, you guys know the medications, the atypical antipsychotics, but I also discovered it's not that common because you will need like one, I think the particular case that they brought up in all the, what I was reading is risperidone, which would be the more likely to cause high enough levels of prolactin enough to cause a milk secretion. And then like other things, like rarer things like renal failure, because it doesn't get cleared out like the hormone, but also chest pain. People with chest pain, apparently it causes some sort of stimulation that goes all the way from the spinal cord to the the hormonal production, like the hypothalamus, and it will increase prolactin levels. So that's why I was looking at this, because I was like, how, fatigue, lightheadedness, like that doesn't really match up. All right.
Thank you, Sandy. Okay, so do I have, okay, how about Max, since you were so eager before? Do you mind going over the history that we have here?
Sure. So she has a past medical history of galactorrhea, breast augmentation surgery, appendectomy, ovarian cyst removal, and tonsillectomy. Social history, infrequent alcohol use, no tobacco or drugs, lives alone, quote unquote, very active. Family history of diabetes in all grandparents, aunts, uncles, no medications, no allergies.
Awesome. Does anyone have any other questions that they would have asked for or would have wanted to know about?
When was her breast augmentation surgery? And what kind of augmentation was it?
Good question. So her breast augmentation surgery was about 1.5 years ago. I don't know what type of surgery it was.
Menstrual history, and could she be pregnant?
Good question. Menstrual history is normal. She has normal periods. She's not on birth control. And she said she didn't think there would be a chance that she was pregnant right now. Okay. Okay. And then does anyone want to read the review of systems for her?
Maybe Frida, since you had a few questions about this precisely, do you mind reading? I don't know if you're somewhere you can
Sure.
read. There you go.
Yeah, so constitutional, no fever, fatigue, eyes, dark spots in the eyes, no headaches, no congestion, no throat pain, no chest pain, no dyspnea, no palpitations, no cough, no shortness of breath, no wheezing, decreased appetite, no nausea, no vomiting, no melena, no dysuria, no hematuria. There is galactorrhea, no swelling, no rashes, no lesions, no focal weakness, AOA times 3, but there is dizziness.
Awesome. Thank you.
Sarah, can I ask you, does that mean she had dark spots in her eyes or in her vision?
Oh, excellent question. So in her vision.
Okay, okay,
No,
cool.
we couldn't see anything. And again, that symptom wasn't really there anymore, but she had it at home, but dark spots in vision. Okay. And physical exam, honestly, as I wrote here, everything was like really pretty picture perfect. Maybe she was a little bit anxious, but like so are most people in the emergency room. And her vitals were really like, I guess besides for a little bit of tachycardia, nothing too impressive.
What other things do you guys have?
Cranial
asked in the
nerves were
physical?
fine.
There you go.
What?
Man wants to know
Cranial-
if the cranial nerves were fine, if there are any deficits. And why are you asking that, man?
I mean, important because of the symptoms she came with, the diplopia and the other ones. If you're looking at bulbar symptoms, if you want to look at the affected like cranial nerves, 2, 3, 4, 7, and you want to see if there's any deficits, which I doubt.
Yeah, no, but definitely good question. And cranial nerves were intact.
I mean,
Was
also
her-
patients, you would want to do a breast exam because you actually
Yeah,
want
that
to
was my
for
question.
discharge, and to make sure it's galactoria and not some other form of discharge.
Yes, no, you're definitely right. And on the initial exam, we didn't do a full breast exam, I think because of like just like how things were going, but we did it later on to confirm that it looked like galactorrhea. It was bilateral, like clearish white, not bloody, and no sign of infection or anything.
Oh, so she definitely had
Sarah,
constipation. That's interesting. Sorry.
Say that again, Sandy?
It was interesting that you actually were able to express something on
Yeah.
physical exam. Sorry, Shareen, go ahead.
I actually know this patient and I feel a personal connection because I was personally sprayed by her breast milk when we were examining. So just a little life lesson to like stand out of the way when you ask a patient to try and express the milk. So I feel like personally connected to the case now.
Your skin looks good, Shireen, though. I feel like it was good.
Yeah, it was like a free like exfoliation situation. Yeah.
Okay. Oh, oopsies.
So
Okay.
talking about skin though, did her skin show anything anything
No.
different?
No, like good question. Yeah, her skin actually was like very clear, like no pimples, no discoloration or anything like that.
Signs of like edema or any other remarkable findings in the legs. Okay, there's a discussion going on in the chat that I'm not gonna read out. That's okay. Private message yourselves about that. All right. Any other questions you guys have about the physical exam? That's a good question, Okar. He's asking if there is any postural hypotension. Do you mind just, I'm wondering why you're asking about that.
It's basically the ACTH, decreased production of ACTH if the prolactinoma is increasing in size. Hypopituitary.
Got it. Yeah, I mean, I guess we didn't test for any postural hypotension or orthostatics or anything.
She seems to be normotensive, but I agree, maybe if you're suspecting, despite the normal neuro exam and the symptoms not being necessarily congruent, but maybe some relative AI could be. Anything else, guys, for this examination. I mean, I do think that when you're evaluating neurologic status, I'm not entirely sure what ANO times 3 in non-focal. I don't know if it gives you the entire like information, if there's anything else, if there are any memory deficits, or if that it would even, and Man just brought it up, visual defects, are the quadrants okay? In the cranial nerve palsies, that's also something to just like keep in your physical exam in case, you know, something happens and you have to go back to see how their baseline exam is, even if it's normal. All right, do you want to go to the next slide?
Sure. I guess before that, does anyone want to, or can anyone give a problem representation?
Nick, do you think you can help us?
Sure. I missed the first half, but I could try.
Ah,
It looks like
maybe
a.
you want us to go to someone else. It's okay. No, that's definitely happened to me before. No worries. Does anyone, oh, Shireen,
I can do
you know
it.
this patient. Go ahead.
Yeah, sure. So we have a 28-year-old female who presents with 2 days of fatigue and feeling like she's dying. On physical exam, only note, actually pretty unremarkable, but review of systems notable for some spots bilaterally in her visual fields and some dark spots, as well as some tachycardia in the vitals. And this has been going on for 2 days.
Excellent.
Thank you so much, Shireen. The
Good
only
job.
thing, if you're trying to be succinct and in a kind of one-line fashion, maybe you can switch to what Sarah just said, young woman. Just, it's easier in this case, but maybe in the future, it'll help you categorize your patients in an age group that may or may not be more prone to certain conditions.
Okay, so fatigue, lightheadedness, blurry vision, and decreased appetite. So does anyone want to throw out some differentials?
Adrenal insufficiency.
Nice.
Pituitary tumor or
Sheehan syndrome.
Probably any type of tumor inside of the, like any head tumor, right? Any cranial.
And I'm going to read in the chat that Frida is saying maybe a prolactinoma, like you said, maybe some sort of pituitary tumors, hypothyroidism, Mariela, maybe like we said before, that could also be linked to the symptoms in the galactorrhea. I'm curious, Andrew, what are you thinking hyperviscosity? Is it related to the symptoms she presented with, or is there anything else that caught your attention?
No, that's just one differential strictly for blurry vision, like something that could be a presentation of some sort of like plasma cell dyscrasia, like Waldenstrom's, something like that.
Which perhaps may be more common for different like patient demographic, but definitely we keep it broad because we don't know a ton about the case yet. Medication effects, Matthew, what medications, or Sarah, what medications were they on that could have, you know, caused these symptoms? And you can.
So she wasn't on any medications, yeah.
And we suspect she was probably okay. So maybe not so much medications in this case, unless she's not telling us the entire truth. What did she do for a living?
She was, I will say she was in general, I guess I wish there was a way of writing this on the physical exam. She was kind of like, she was like pretty vague. Even when we asked her about what she does, she was vague. She just kept saying she was like active, and in some ways had like a strange affect. So it was like a little bit hard to get an accurate history from.
So we don't know what she does for a living, and maybe there's some sort of personality that may have been a barrier.
But besides for that, like she was there with her sister, and she seemed like pretty, like maybe she was like a little like sneaky with the history, but besides that, she and her sister seemed like pretty normal and with it, I'd say.
Okay.
I don't know if this helps, but I think works for an airline, like an air hostess or something. But she's not. We wanted to find out if she was in that medical field or has access to like.
And why is that,
medication.
Shireen? Why do you want to know if they're working close to healthcare?
Wait, have we covered labs yet? I can't remember. We haven't,
No, but
right?
that's you
So I
can
don't want to
throw
give
your
anything away,
ideas
but
out there without giving away.
we
the
were
thing.
kind of, yeah, we just wanted to know if which kind of medications were, whether they were like prescribed or non-prescribed. Like some people with certain psychiatric conditions might like be taking medications that they have access to, which could have various side effects. So we kind of wanted to figure out if she was in healthcare.
Or maybe even an antipsychotic or something that we don't know about, right?
Yeah,
Sara,
like
I have
working at a nursing home or something.
Was the lightheadedness, was the blurring of vision in relation to the lightheadedness?
Yeah, it was kind of like all together. Mhm.
Okay.
Okay.
Yeah,
Oh.
sorry, I just wanted to, because people suggested so many interesting differentials here. Just to bring up, well, tachycardia could go against hypothyroidism. We don't really know like the state in which they had this one measurement, but perhaps. And even diabetes, eating disorders, and hypoglycemia could cause symptoms like these, and they should be part, as you see, of the differential. And then infection and inflammation, for sure. Yeah, infection can definitely cause in blurry vision and some of the symptoms she's presenting with. Sorry to cut across, Sarah. Go ahead.
Oh, that's okay. So everyone thought of amazing differentials, and here's just some more. But obviously, her symptoms are pretty broad, and it could really be anything at this point. Okay. So what is your immediate management of this patient? What's like our magic vital sign during rapids?
Glucose.
Yeah.
Finger stick.
Good job. Okay, excellent. Okay, now can anyone read our updated HPI with, I guess, a pretty vital piece of information?
Nick, I'm going to give you a second chance.
I could handle it.
Nick's really good at reading.
20-year-old woman, a history of galactorrhea with 2 days of fatigue, lightheadedness, feeling like she's dying, with dark spots in her vision, headache, decreased appetite, reports never having similar symptoms, but has been having ongoing issues with galactorrhea on and off for 2 years, finger stick now 48 on arrival, improvement with PO intake and D5 with recurrent hypoglycemia to 59 6 hours later.
Awesome.
So if I may play you can leave that slide. No, the next slide should be fine. It doesn't really matter, but I want to play the role of a future endocrinologist here. And like when we talk about, like you said, it's not necessarily a vital sign, but we do consider it like one of the most important things. I mean, you guys run to RRTs, particularly second years. One of the first things to check is glucose. It can give you so many symptoms. Hypoglycemia, we used to say it's like, oh, less than 70. And obviously Max and Kirsten, who I know are like future endocrinologists as well. We used to say it's like less than 70, but really guidelines actually argue that because, we can't say that a single plasma glucose concentration can give us a definition because this could be fake, right? And what they usually say is that it has to be low enough to cause symptoms. And these symptoms are usually, like you were saying before, maybe some sort of impaired brain function, right? So that will differ because this is really non-specific. And we usually say, well, I'm super hungry, I'm neuroglycopenic, or I say that because I'm a little nerdy, or maybe you have some sort of other like neurogenic symptoms, and that's like the anxiety they feel, the tremors, and that's when you're asking your patients, it's really important to know, do they feel palpitations, sweaty, numb, whatever. But there are also other autonomic, responses that they have in their bodies. And this is really like, across the board, very, very non-specific. So that's why they came up with something that we may touch upon later on. That's called the Whipless Triad. And you basically just have symptoms of hypoglycemia, low sugars, and the correlation of those. And that's what you really need to look for, because not noticing hypoglycemia, and this goes for your Ryan patients as well. Bear in mind that having a high A1C doesn't mean that you are consistently hyperglycemic, it might just be a combination of both, particularly in patients that inject insulin. So what we have to know is if you have prolonged and you have profound hypoglycemia, that causes brain death because your brain cannot make any sugar. That means that you need to constantly have glucose in your circulation. And in healthy people, actually, we can reach levels of like 55 without having any symptoms because we do have counter-regulatory hormones that help us combat hypoglycemia. So they'll decrease the insulin secretion, they'll produce more epinephrine, and that's sort of the response that we'll see. And we'll walk together through the labs to see why certain things that we notice. And of course, Sara, go ahead and if you want to share.
Sure. So here we have the labs. I guess I highlighted the things in red that are abnormal. The pH was 7.1, that should have been red. But besides that, you could see the glucose is 48, cortisol somewhat low at 5.7, beta hydroxybutyrate 4.45, and UA with ketones and proteins. Otherwise, as people asked before, negative for pregnancy, which is important, and UTOX and alcohol screen was negative.
Sara, is the cortisol an AM cortisol, or was it a random, like in the middle of the day?
Sure. It was, I feel like it was a random, to be honest. So you're right. So then it would be important to get, excellent question. And then it would be important to get an AM cortisol to confirm.
And it's reasonable to ask for cortisol because you know that AI and like what Cara was mentioning before, it could lead to hypoglycemia. In this case, it doesn't seem like she's normotensive. There are no other signs like the rest of her electrolytes seem to be okay. But you do have to know that even if you measure cortisol that seems to be low with hypoglycemia, it doesn't necessarily mean that you have adrenal insufficiency. And this is basically because people that have recurrent hypoglycemia, their threshold is different for secretion of cortisol. So you may find that even if they're superbly hypoglycemic with a glucose of 48, they don't have like a great cortisol response. So in the other labs, does anything else like, you know, catch your attention in what you're seeing? And the perfect thing is that you have highlighted in red the abnormal lab values. What do you guys think? Max, what do you make of the beta hydroxybutyrate and or the ketones in the urine? And you can combine that with maybe the low bicarb, and I'm quite shocked about the pH, but I guess we'll talk about that. And you are muted, so I don't know if you are trying to. Okay.
Yeah, so I mean, we definitely have an elevation there in terms of the beta hydroxybutyrate and low bicarb. And as you can see, we have an acidotic state overall. I mean, it's tough to say if it's a euglycemic DK because she's hypoglycemic, but I guess something along those lines. Oops, sorry.
And perhaps in this case, even without medications, that'd be less likely. But you do know that we don't really know what this person has been doing. Maybe like you said, Sarah, it's a little difficult to obtain a good history. But if you are fasting, you need 16 hours of fasting to get like a minimal increase in your beta or your ketone bodies, right? Which is what your brain is using when you can't use glucose. It might be like mildly elevated with a low bicarb, maybe in the setting of fasting ketosis, but I'm a bit, you know, I don't know. I took the liberty of calculating like the anion gap and like the delta ratio, whatever, and it doesn't really match up. And even if you have like fasting ketosis, which like I said, it might not be like there's no hyperglycemia, so it's not necessarily like a DKA or even like a euglycemic ketoacidosis, because it is hypoglycemic, which could not, I don't know how that would be consistent. But even in the setting of ketosis because of starvation, you wouldn't expect such a low pH. So maybe there was something else going on there, or maybe we just need to like albumin and see what her, what the correction would be. I'm not entirely sure. Yeah, exactly. I think, and you offered a TSH as well, which seems to be normal. Which, like we said, hypothyroidism leads to like relative AI, and that could lead to like impaired counterregulation and hypoglycemia, but that seems to be ruled out.
Okay, so what other labs would you want at this point? You could just throw out things.
The whole pituitary panel.
Say that again.
What is that, man?
The whole pituitary panel. Like if you're looking at something like central causes, because I don't think they may not be like part of the same process. They maybe like two processes going on, like starvation ketoacidosis and hypoglycemia due to another reason. I don't know. I would want like insulin C-peptide with the episode of glucose. You want the glucose to be low, and pituitary, which I mean like LH, FSH, insulin growth factor 1. What else? ACTH maybe.
Great.
Yeah, that's very reasonable. And I would add, if you're collecting all those things, might as well collect glucose in a grade 2, because once you collect glucose, if it doesn't have like an enzyme inhibitor, the metabolism of those cells will continue to be there, to be present, right? So you may see like a pseudo hypoglycemia in some of the other methods of collection, or the other tubes, because of this. So maybe that's perfect. You said C-peptide and maybe proinsulin, and because you're looking at the insulin production. And maybe in this case, Sarah, since she's like, you don't know what medications she may or may not be taking. Anything else you guys would like to add to that?
An SU drug screen.
Okay. Yeah, exactly. Because that could lead to hyperglycemia. Yeah.
Excellent. So here are, I think you guys basically covered all of them. But these were the labs. And actually 2 of them are still pending, but really for the most part, they were pretty unremarkable. And then even her pH improved also.
Do you know if those were drawn by the time she was hypoglycemic or normoglycemic?
Good question. So these were drawn, so as I think you're alluding to, they're actually supposed to be drawn when, at least per our discussion, they're supposed to be drawn when the person is hypoglycemic again, but she never actually ended up being that hypoglycemic. So I think they were drawn when she was like, maybe like 59 or so. Where at least per our discussion with endocrinology, it was like when below 57 is when you should get them, because that's when they're the most accurate, but we decided to get them anyway.
Shabri, can I ask you something? Let's say you have a high plasma insulin, you have a high C-peptide, and you have a high proinsulin level. So high plasma insulin, high C-peptide, and high proinsulin level. What would you suspect in a case like this, in someone that's hypoglycemic?
Doesn't that help you differentiate between naturally secreted insulin and like a insulin, as opposed to like externally, like a medication, you know what I mean? Like,
yeah,
I think
absolutely.
C-peptide is part of the naturally, I think, secreted insulin in the body.
Yep, exactly. Like the precursor, the insulin itself, and like it will create C-peptide in a similar amount, definitely. So in this case, it's kind of like, oh, they're looking to see if this is an insulinoma versus if she's like maybe injecting. But you would see it, let's say if I have someone that's using insulin, then what would you expect to see, Athena, with the the proinsulin and C-peptide levels? Let's say this person's hypoglycemic and they are injecting exogenous insulin.
So the C-peptide would be like normal or low. Actually, it would be low. And then the proinsulin would also be low in that case.
Right, because your body is not producing it because it's obtaining it from somewhere else.
Okay, cool. And then I guess, so then if we wanted to go ahead and do the ACTH stimulation test to rule out adrenal insufficiency, and again, this we did after we got all those labs. Does anyone know how it's performed, or at least like roughly the idea or the theory behind it?
The question first, do we, yeah, sorry, I just want, are we thinking of adrenal insufficiency as the working diagnosis here? And, or no, we're still just investigating?
Yeah, we're still just investigating. And I guess because, you know, we were trying to figure out why is she hypoglycemic. And as you kind of saw the previous slide with all those other pro-insulin and C-peptide labs was really pretty unrevealing. So we didn't feel that there was, I guess, like a diabetic or an insulin etiology at this point.
So Sarah, based on the prior slide, just to conclude, because I don't know the normal values for all of them, we usually look at them like next to it. So what was normal, what was abnormal? Just to conclude, I'm not sure.
Sure. So I should have included the normal ones, but because I didn't highlight any red, they were all normal.
Okay, great.
Yeah.
Yes.
But I should have clarified that. Does anyone know how it's performed? And if not, I'll just go ahead and explain it. So you would check the baseline cortisol and ACTH at 0 minutes. So you get those labs. Then you'd inject 0.25 milligrams IV of cosinotropin. And then you check the cortisol at 30 minutes and 60 minutes. And you would hope that the cortisol would be between 18 and 20 for a normal patient without adrenal insufficiency. And as you can see with our patient, at 30 minutes, it was 19.3, 60 minutes, 23. So everything looked pretty good and normal. So that was reassuring.
Sarah, sorry, can I just add a little snippet that I learned about the cosinotropin test recently? So 2 things. One, I think as per the latest guidelines, you only need the cortisol to rise to 14. I think they changed the cutoff from 18 to 14. Okay. That would be sufficient. And then I think, secondly, the only thing that this rules out would be like primary adrenal insufficiency, because you are giving the patient cosinotropin or ACTH. So it doesn't actually rule out an ACTH deficiency. And then thirdly, I think more and more people are tending to not do a stim test inpatient. They'll either, like what guidelines are moving towards are like, if you're suspecting AI inpatient, then just give the patient steroids, and then outpatient, you can do a stim test. But there's like decreasing utility, I think, to doing a stim test inpatient.
Yeah. And I guess, you know, to that, like we actually weren't like, we didn't really think she had it, so we wouldn't have been like empiric steroids. But thank you, that was really interesting. Oh yeah, so what imaging do you want?
You're probably getting MRI brain, like pituitary specific.
Yeah.
There's thinner slices.
Exactly. So as you can see here, a long description, but it was normal. So no large mass. Okay, so now for our discussion. So does anyone, Sani was just talking about Whipple's Triad. Does anyone remember what's included in that?
You have to have a documented hypoglycemia, along with symptoms, either like CNS symptoms or whatever kind of symptoms you get, along with the serum hypoglycemia, and you have resolution of those symptoms after you repeat the hypoglycemia.
Awesome, exactly. Okay, and can anyone define reactive versus fasting hypoglycemia? Is anyone familiar with those phrases?
So fasting is obviously fasting, like on an empty stomach. And then reactive is usually after you eat, when there's an insulin spike. Or I think there's some other conditions. I think some like post operative conditions. And then also if there's a high amount of insulin resistance, I think that spike can lead to hypoglycemia.
Yeah, exactly. Thanks, Kirsten. So that's right. And just a little bit more. So, fasting hypoglycemias, it would be like probably at least after 8 hours of eating, and a healthy person still shouldn't become hypoglycemic because they would break down glycogen. But someone who does have some sort of issue going on could get hypoglycemic even after 8 hours. And you can see some of the causes of it. And reactive hypoglycemia would be more like 2 to 4 hours after eating. And here are some of the causes of it. Okay, does anyone know what the, I guess this is based on one of her other problems, not the low sugar, but does anyone know what the hook effect is and how it might be relevant in this case? Okay, so the hook effect, I wasn't familiar with this, but the endocrinology team was like saying it very loosely. So apparently it's a common thing, and it can happen sometimes if there's a really high amount of a substance, for instance, prolactin in the serum, and then it can kind of like inundate the other substrates in the lab and then not let them bind, and then you can have a falsely low level of prolactin. So of course, for someone like her who has symptoms, you'd want to know if the prolactin is actually high, because then we could definitely medically treat it. And then another thing is it is also important if someone let's say you found that someone had a pituitary mass, you would treat it differently if someone had an elevated prolactin versus if they did not have an elevated prolactin. Because if they have a mass but a normal prolactin, the only treatment would be surgery. But if they do have an elevated prolactin, then first line would actually be to medically manage it.
And in the other end, you also have to think of people that have a high prolactin level. There's something known as macroprolactin, which is just prolactin bound to IgG, which makes it way bigger than just non-IgG bound prolactin. And it gives you a higher level, but it has no clinical significance. So you repeat the lab knowing that this could happen. And in patients, and I know that maybe this was prompted by the galactorrhea, the imaging and the workup, but you have to know that even though it's a low level recommendation in patients that have galactorrhea with normal prolactin levels, you wouldn't ideally pursue this workup. So that, in this case, obviously we weren't sure what was going on, but maybe even this patient could get away without an MRI for, the AFFB.
Got it. Thank you. So again, here's a compilation of the hypoglycemia workup. So the cortisol, insulin, C-peptide, insulin antibodies. And then number 2, kind of as Mon was alluding to before, ideally you'd get these other labs only when they were actually hypoglycemic. And then we have the stimulation test below. Okay. And then here, I thought was like a handy table. We don't need to go through all of it. But, in her case, we were lucky that all the labs were relatively normal. But here you can see on the table, based on the insulin level, C-peptide level, proinsulin, and antibodies to insulin, you can see if the cause would be, let's say, exogenous insulin, an insulinoma, someone taking oral hypoglycemic agents, an antibody to insulin, IGF, or something that's not insulin mediated. So again, for workup, you would do the labs. If, let's say, there was concern for adrenal insufficiency or for an insulinoma, you'd consider adrenal imaging, of course, family history, personal history for substance abuse, concern for eating disorders. And then, of course, for management, you want to frequently check their blood sugars, treat with PO, and then again, ideally you would get those special labs only when they were hypoglycemic, so you'd want to be ready with the tubes to get those then. I guess again, so kind of in her case, as you can see, the workup was like was pretty inconclusive. In the beginning, we thought, oh, it's reactive hypoglycemia, even though it's unrevealing. And so we did treat her with diabetic education and just really regarding the need to eat every 2 hours. And we did send her home with a glucometer so that she could check and so that then she could correlate if her symptoms were always when she was hypoglycemic. And then for the galactorrhea, again, we'd check prolactin. If within normal limits, you could call the lab to rule out the hook effect, and then they would run it again like they did in her case, and it was still normal, plus minus MRI pituitary. And then, as I said, if mass with elevated prolactin, medically manage. If mass without prolactin, surgical intervention. And does anyone know offhand what meds you would use for galactorrhea with elevated prolactin?
Dopamine antagonist, or sorry, agonist.
Cabergoline, bromocriptine, cabergoline.
Excellent. Yep. So first line cabergoline, second line bromocriptine. Apparently cabergoline has a better side effect profile, and it's weekly dosing, which sounds more convenient. So the illness script, so obviously hypoglycemia can affect anyone and everyone, and it's as we've all said, it's like almost like a vital sign, and it's especially in rapids, it's kind of great when someone's actually hypoglycemic because it's the most easily treatable thing, I'd say. And then you get to like save the day. So symptoms, as we all knew, fatigue, irritability, vision changes, palpitations, impending doom, seizures, triggers, low PO intake, genetics, medication, why, all these reasons we spoke about, including poor PO intake, adrenal insufficiency, insulin or IGF secreting tumor, exogenous medication, normal use or abuse, bariatric surgery, and management assess for insulin secreting tumors, adrenal insufficiency, and extensive education. So I thought this was like an interesting case because kind of as in our discussion, how I thought it was interesting how Sani brought up that the MRI wouldn't have necessarily been recommended. And then Kirthana brought up that the STIM test wouldn't necessarily have been recommended. And actually, when we were taking care of her, I remember I didn't speak up about this, but I was like, I feel like this is like a really big workup for someone that maybe just wasn't eating enough. And then we had a new attendant come on service, and she kind of said what I was thinking, that this patient had hypoglycemia, probably just wasn't really eating. And the more we spoke to her, it seemed like she wasn't such a big eater, and even her sister made some comments. So, I mean, it was, I guess we were able to like reassure her and reassure ourselves that there wasn't anything bigger going on. But in some ways she really, she kind of passed the test. She came in hypoglycemic, we fed her, she got better. And then, yeah, maybe she got a little bit hypoglycemic a couple hours. But then we ended up fasting her for 72 hours because we were trying to wait for her to get hypoglycemic to get those labs. And she ended up never getting hypoglycemic again. Yeah, so there you go. So I guess this would be maybe more of the workup if someone had truly more persistent hypoglycemia. And yeah, any other questions, or does anyone have any input or anything?
Thanks for the presentation, Sarah. Can I ask you two other questions? One was, did you guys ever do a pregnancy test on her? And two, Did you mention her substance use? Did she say that she was ever smoking marijuana consistently?
Good question. Yeah. So firstly, we got a pregnancy test on admission. It was negative. And she denied all drugs, said like occasional alcohol.
And her Utox was negative too, you said, right?
Correct. Mhm. Yep.
Thank you so much, Sarah. That was a fantastic presentation.